is the having to take excising fibroma is a different reactive hyperplasia. This is the peripheral variety, that is the growth of gingiva is seen, but sometimes it may have, since it is a giant cell lesion, it may have an attachment to the bone and there is a cupping that can be noted. And again, the care has to be taken and the patient should be warned that it is likely to recur sometimes. So the patient will know that the doctor has already informed us. This peripheral giant cell granuloma also has got some central variety, that is CGCG, central giant cell granuloma. This central giant and soft tissue swelling coming in the oral cavity, a growth coming in the oral cavity, you should be always suspicious of having its bony component, and that has to be ruled out by the proper examination. Brown tumor of hyperthyroidism, hyperparathyroidism, that is present. I mean, once, if at all you find the should always suspect this entity if the patient is having, and the further investigations you should do, and PTH level, and if needed, you should take a physician's opinion for the same. Then capillary hemangiomas. These are the some of the presentations of we should take care of all these things before you actually plan for your excision. These are the other presentation of a capillary hemangioma. See, this is a case where the teeth were extracted previously and there was a residual cyst is present. The residual cyst was not present and the excision was done after of the soft tissue, and there was a bleeding noted, and this is a case of a capillary hemangioma. Again, one of the interesting case where there was a carious tooth and the and this pulpal involvement, and probably there was a growth outside having this pulpal pathology which is manifested outside, or the lesions which we had seen previously like pyogenic granuloma. It is classically looking of that, but this turned out to be a capillary hemangioma. After excision, you can do the root canal treatment of this tooth and proceed further. Hemangiomas may easily be confused with pyogenic granulomas. Attempts of excision, diagnosis, and good surgical therapy may lead to the serious medical problems. Hence, diagnosis and the risk involved should be considered, and necessary precautions should be taken prior to the excision of apparently innocent lesions. In such cases, diagnosis can be accurately made by the histopathological assessment. Lesion is large. Here, you can take incisional biopsy too. Hemangiomas, oral cavity, but may be seen in the head and neck areas. So these are some of the presentations of hemangiomas. Like the case, it is having some bluish tinge in this, and that is making us suspicious of not having normal swelling, and it is having something and you have all the lesions which can mimic this in your mind, then only you should further plan for the treatment. And even to the patients in such cases should be avoided. See, this is a case, probably I'll explain afterwards, a diascopy which has to be done to perform, to find out having a diascopy, that is the glass plate should be put and should be checked for pallor if the blanching is there in the lesion. This is a small case again, capillary hemangioma, which was been treated, and you may need to put a sutures and take a proper care. And that is probably taking now will be a treatment model. These are some of the other manifestations of hemangiomas and vascular malformation. Say it can be a present as a small and even a large lesion. The size of hemangiomas may be variable, ranging from few millimeters to several centimeters, in the form of macule-papule nodule or a tumor with elasticity. So whenever suspicion of a vascular lesion in the mind, and then you should plan your further investigation and the treatment. This is the case recently we have reported in our department. That is, we are not sure about the diagnosis. The patient was reported with enlargement of a tongue, and you can see the half enlargement tongue. And there were the lesions is enlarged here. And this case we are not operated yet. This has been kept under observation. So these can be some of the presentations. It is having the other manifestations also. This has been sent. It is under investigations, and probably in the next presentation, I'll be able to tell you about this. Called as a superficial hemangioma. Cavernous should be called as a deep hemangioma. Capillary and cavernous hemangioma, combinedly, they are called as a compound hemangioma. This also has got a central variety, and the hemangioma can occur from the bone and can manifest outside. How the teeth are I mean, you can see the trabeculae which are being seen, and that is making the diagnosis, typical diagnosis of a central hemangiomas. So suspect hemangiomas, like suspect vascular lesions, nearly in all cases, do chairside investigations. That is the dioscopy, which I had shown in the first slide. Put glass plate or then definitely the lesion is having a vascular vascular origin, and you need to take a treatment according to that. Hemangiomas radiological examination has to be done. Even sometimes the aspiration may be dangerous. They also have to be. Here you should take anywhere. Careful way, you should approach the lesion from the normal mucosa and slowly inject, slowly go for aspiration into the lesion and then aspirate. So there are less chances of a bleeding, and the bleeding won't be causing any danger there. So that care has to be taken. I still remember there was a case been drained by considering periodontal abscess, and then it was which was been replaced by 8 bottles of the blood. Okay. So now this is a new case which I wanted to show. Periodontal cyst mimicking as a lateral periodontal abscess. So the patient had come with a swelling present on the lingual side, if you can notice here. Okay. It was looking like that, which has to be done. If you can notice some sclerotic or cortic border here, that made a suspicion of that this lesion is not a periodontal abscess. And then the root canal treatment of this patient is carried out, and once it has been opened, proper surgical cavity was being seen, which was showing that it was not a where see again there is a looking like that of the periodontal abscess. This is the case had come when the radiograph was being taken. It was been showing some radiolucency, but only drainage was suffice in this case. Like this was mistaken as an apical abscess, and probably some would have been gone of the tooth, which was been not needed. Only drainage. Wanted to emphasize that before going for any treatment, diagnose the lesion properly and then initiate the treatment. Acute periodontal abscess, which was mimicking as a acute apical abscess. Now, this is again one case where the root canal treatment and the in the furcation area. So once the probe was been put, the root canal treatment was properly done, and there was swelling on the 4-6 aspect, and the suspicion was given as a periodontal abscess, or because of a periodontal pocket, the probe was going inside. But once after the investigation has been taken, see the was showing the buccal bifurcation cyst. Now this entity, I mean, we hardly have seen these cases, such kind of a cases, but such kind of entities do exist. And if such case comes in your this thing, you should have the suspicion of having the cyst in that lesion, and proper treatment should be done. Then only you should. Periodontal cyst, which was mimicking as the periodontal abscess. See again, there was a pocket formation, and this pocket formation, the OPG was being taken. And if you can see, there is a suspicious why the pocket should occur in such a child, that too when a problem gingiva suspicion led the doctors to take the OPG, and the OPG was showing the periodontal cyst, and then the periodontal cyst was excised. Okay. Now this is a case, again an interesting case, where this thing, the gingival abscess, or this thing abscess swelling, which instead the once the lesion was opened and it has been done, it turned out to be the this thing B cell lymphoma. And again the management varies, because that is not a sufficient, I mean, it should be taken out very the excision should be done carefully, and the patient should be suspicious of the patient should be taken out. That care you should take. This entity needs again attention. Gingival enlargement, like you may be coming across with many cases, and nearly more than 70% are turned out to be because of the inflammatory gingival enlargement and fibrotic gingival enlargement, drug-induced gingival hyperplasias. All the faculties, all the students are aware of the drugs, anti-hypertensive drugs, anti-epileptic drugs. Take the history properly and see if the patient is having a long-term drug history, probably with the help of a consent of a physician, and they in such cases. Now, this gingival abscess and gingival hyperplasia, we had a case of gingival tuberculosis. If you can notice, whatever the presentations previously I had said, shown it to you, and these cases have seen that too in a small child. So that was a suspicious lesion, and this case was diagnosed as a gingival tuberculosis. So unless you start the treatment of a tuberculosis, we cannot move further. So such kind of a suspicion should be in the doctor's mind. Diffuse this is another. Gingivitis are the manifestations of many diseases. Like this case was of a penile mucous membrane pemphigoid, but it can be seen in the pemphigus, oral lichen planus also sometimes. And desquamation, that spilling of the gingiva. The gingiva is nearly fiery red, near to the fiery red rather, and it can be that has to be suspected. If you can notice in this figure itself, there are no local irritations as such to cause the so much of a gingivitis. So something suspicious should be in your mind, and what it could be, that investigation has to be done, and then only it should be followed out. His sign, as it like rubbing of unaffected skin forms the new this thing. In fact, that can be noticed in the oral cavity also. Like rubbing of unaffected oral mucosa may form a new lesions, and the new lesion was formed here. And before seeing that new lesion, the new lesion was, I mean, there was a manifestation of a present in that disease. See, the desquamative gingivitis, some of the other manifestations that was present in the paste allergy case. This was present in the atrophic lichen planus case. and it was a non-specific disc commutative gingivitis, the third one. This is an interesting case. There was a strawberry gingivitis, like the gingivitis, the inflammation was looking that type of the strawberry like, and it was the first manifestations of Wegener's granulomatosis. Like, I mean, this was not a routine entity what we come across with, and if you see such kind of atypical manifestations regarding the same, and we should proceed further. Like, this was the criteria given: ulcerative lesions in the oral mucosa or nasal bleeding or inflammation, nodules, fixed infiltrates or cavities in the chest radiograph, abnormal urinary sediment, and granulomatous inflammation on biopsy. That is the criteria for Wegener's orofacial granuloma if we suspect such kind of the diseases. Now, this is again the lesion looking like, when I show this, the lesion is looking like that of the large palatal abscess. But what was suspicious in this case was some discoloration, which is not on the posterior side, which is not matching mucosa, and that tinge is made, the aspiration was done, and see the radiographic findings, the CBCT findings, and it turned out to be a mucoepidermoid carcinoma. The lesion turned out to be a mucoepidermoid carcinoma of the hard palate. So minor glands are present on the posterior side. So this lesion is quite common. Kind of the things come. Lesion palpation may also give you the clue for diagnosing these suspicious lesions. Now we are aware of these entities, mucocils. This is little uncommon presentation of a mucocil. Like, it is moreover looking like that of the vascular lesion. Okay, and much more vascular lesion won't manifest such. So it was been treated and excised, and that turned out to be a mucocil. It was looking like that of the hemangioma. This is another presentation. This is a classic presentation of the mucocil, which is, I mean, minor salivary glands where they are present. It is because of the mucus retention resulting from the obstruction of the duct or a minor trauma to the accessory glands. Now, this is again a lesion. Okay, just see what it could be. The lesion was turned out to be a meso-like lesion, like an endo. Okay, manifestation of a maxillary sinusitis. And if you can see this inverted U-shaped radiolucency on the palate, on the palatal aspect, on the near the palatal root, that is making a suspicion of this lesion. So lesion was extracted and also curated and was given for a biopsy. Now, again, this is a case report where there was an incidental finding of actinic cheilitis on a localized, which was localized on the lower lobe. Like, the patient had a telemedicine, like a patient has called a doctor, and the patient was worried, which was being checked out, and the patient was probably having a consultation of how much it will cost, doctor, and when should I come. I don't know why the doctor has in the mind. He said, if he can take the photographs and send me. The patient has taken the photographs and shared with the doctors. The doctor said, there is something on your lower lip also, which have you not noticed? It is chipping off once or twice, and then the lesion was diagnosed as actinic cheilitis. I mean, you also can practice the telemedicine, I mean, teledentistry, and we can ask the patient to give the photographs. You do not give the proper diagnosis there itself, because we have not seen the lesion, so we see the lesion. I mean, we can guide the patient, and because this lesion was seen, then only the doctor made him to come and visit him immediately, and further treatment will be taken care of. Now, fellatio associated with erythema of a soft palate, an incidental finding during a routine dental event. Patient has come, but see this thing, and oral sex is becoming quite a common nowadays, and we should all have a suspicion in the mind and make the patient take, I mean, ask privately all these questions. If at all you build up a relation with a patient, like there is a suspicious thing coming in the mind, and then only take kind of cases, because many of the patients won't like this, but we should come to a diagnosis for that, and this has to be taken care and not mistaken for other pathologies. These are the other pathologies that can be mistaken for this disease. Now again, while examining a tongue, posterior lateral swelling, which is a normal variant, so leave it, but that is not this thing. You should palpate it, and once after palpation, it has to be then it was been further investigated, and the lesion turned out to be rhabdomyomatous mesenchymal hamartoma, and that has to be taken care of. And this way, all the lesions which are coming mild be done. If needed, some chairside investigation has to be done for the further diagnosis. You all are aware of these entities. This is silolith that is present with a manifestation. This is a giant silolith I'm sharing with you. The patient will obviously have some manifestation. The patient to that will make the diagnosis very easily. This is another case, and this is what is a silolith, which is found in the parotid gland. Parotid silolith. What is the speciality of the parotid silolith? See, we can notice this. They can appear as a radiolucent. And then only you can record the case. Phleboliths. This is a case of a multiple phleboliths. Like this was again done when a patient has come for a routine examination and the patient's history was taken. This was a 56-year female for the dental examination, and after doing all these things, OPG was taken. Present on the right side near the coronoid area, superimposed on the coronoid area, and then the diagnosis of maxillofacial area, asymptomatic presentation, the diagnosis of a phleboliths was taken. What care you should take? The care while doing any surgical procedure, the risk of hemorrhage is quite more. Okay. These are the some biopsy. Now, this is a classical examination. I mean, anybody can tell that this is looking like a leukoplakic patch, sir. But why we need to investigate? Because of the site of the leukoplakia. This is to be, having a maximum potential to turn into malignancy. So before you have to make kind of the lesions are present. The patient was keeping a tobacco here, and see how the manifestations have come out. And before going for a further these things, it is already showing some cracked mud appearance. That is a classical appearance of a leukoplakia from a tobacco pouch keratosis, which I mean, it's a further we have the further cause, and I mean take care of the turning into the malignancies also. Now this is again a case which was been seen, exophytic growths. Okay, one discussed initially, but these are some of the malignancies which are being manifested, and that has to be taken care of. Okay, see again, this is one of the case which was been reported in department itself. The lesion which is present on the floor of mouth, this is again very dangerous. The floor of mouth has got the highest chances of turning patient aware of these things, right? Now, this case, what it is looking like of that? There's a small swelling on the tongue. I have shown a presentation like hemangioma, but it is not having a bluish component which was been there on that lesion. Again, you may feel this is something nodule, indolent nodule, which has been present. But once it is aspirated, then causes, because after the aspiration, it was been proved to be a actinomycosis. So we never know what kind of a lesion is there once after we see the presentation. So before you actually plan the treatment, especially if you plan a surgical treatment, you should do all the thorough investigation to be other, and that surgical intervention. Now, this is the case. See, there is a gingival enlargement, which was been probably seen in obviously here. Swollen gums, the swollen gums were there, and once the radiograph was been taken, the tooth was impacted. So, what is the in the mouth like this history? What the patient has given, there was a foreign object put into this, probably one stick or something else that was been put into this. That is rising the suspicion, and this again it turned out to be a actinomycosis of the periodontium. Once the surgical cavity is being opened, the issue is coming for the histopathology. The further treatment is being done of taking the tooth outside this thing. If it would have been a suspected dentigerous cyst, probably the surgeon would have thought of extracting that tooth also. Okay. See, the patient had come for orthodontic treatment, and during the OPG, during in the area, and which was been further investigated. Here also on IOPA, taking a close view of an IOPA, it was been not visible completely. So what option we are having right now is a CBCT. See how classically the CBCT is showing it. And there was a odontogenic keratocyst, which manifestation that orthodontic consultation. So all thorough examination has to be done before you start your any treatment. The case which has been reported in our department, the cystic lesion, which has to be a globulomaxillary cyst. Nowadays, they say that this entity doesn't exist and just as a only. Then we must consider human immunodeficiency virus infection, because nowadays it is the fourth leading cause of the death worldwide. And oral manifestations, they may be a frequent sign, and the earliest signs may be present, and the dentist 80 to 90 oral manifestation. So see, this is a case of this thing. A coated tongue is present, and this thing, the herpes simplex, which is present, the herpes infection, which is present at unusual site. This is not a usual site for the herpes in the adults, at least. And then the Kaposi sarcoma, which is the diagnosed infection, is a median rhomboid glossitis. Then there is one non-healing ulcer. See, ulcer is very small. The ulcer is very small. The persons may just put some topical applications and try to try to manage it, but still it is not healing. But may not be expanding also, but it is not healing. That's it turned out to be a non-healing ulcer. There were foci of tuberculosis in the chest, and this was a tuberculous ulcer. So unless you start the anti-tubercular treatment, this is not going to heal. So that correlation one should try to make, and then only you should be diagnosing the lesion. See, again, it is denture irritations, which was patient wearing it. But this case was of a tuberculosis lesion, which was been missed as a denture irritation hyperplasia. Okay. So unless here also ATT has to be started, then again one plasma cell granuloma, which was been misdiagnosed as epilis. So any that is the case, plasmoblastic lymphoma, that was been missed as a pyogenic granuloma. Thus, a lesion is looking like that of the fiery red area, and anybody can just make the diagnosis of pyogenic granuloma, but this turned out to be a lymphoma. It was a probably the denture irritation, and there was a lesion inside. Probably the photograph is not showing that much clear, but this was a squamous cell carcinoma secondary to the lung metastasis, which was being diagnosed as the denture induced fibroma. So the care must be taken to you take do the examination of a whole body and then further examination. This is a typical case which I had during my PG life, and that was, I mean, a very nice case which I had come across. The lady had come with a swollen swelling on the left side of the chest, resembling maybe acute paratitis. She was having a little bit trismus here, and then we had gone further investigations, and we had aspirated this lesion, and it was showing collection there, and that collection was showing some granulomatous lesion inside. So this was a case, even if it was okay, but to the surprise, the X-ray chest of this lady was normal. So, what is the conclusion drawn? That even the oral lesions can be present without any systemic evidence, like without any having a primary foci in the lung. So, the tuberculosis is so widely. Then see, probably the manifestations which are there here right now, they itself are suggesting, these manifestations itself are suggesting that this is not a case of a normal gingivitis or periodontitis. See if you can notice the ulcerations. The gum are inflamed in some, how between, and other time it is a blanching. So this is a case of a tuberculosis, gingival tuberculosis, and there was a bone loss also associated. And then after giving a ETT treatment and oral prophylaxis, this case was been treated. Clinicians need to remember that oral tuberculosis is it is so rare. The diagnosis must be confirmed through biopsy, histopathology, or microbial culture and acid-fast bacilli staining in the specimen or tuberculous bacilli culture. Sputum culture is required for the diagnosis. Patients at most risk are those who have defects in the oral mucosa caused by the chronic where pathogens can reside. Persons who wear the dentures should be checked regularly for proper fit so that they don't create conditions that can lead to the development of ulcerative diseases, including the tuberculosis. Okay. Now, this is pseudomembranous candidiasis and erythematous candidiasis on the palate by the, if the topical antifungal agents are not showing the remedies, then suspect some other disease that is causing this, and the approach should be given in that sense. Erythroplakia, again, a pinch malignant lesions. I have not seen a case till this date. People present, they call it as erythroplakia, but that is not the case. The erythroplakia should be observed very carefully, and then only after biopsy, confirmation for biopsy, it should be given as a named as erythroplakia. Like leukoplakia, like if you cannot classify this lesion in any other categories, then you can call it as a leukoplakia, but that has to be confirmed after biopsy itself. Which about is syndrome, oral and perioral manifestation, that this see the patient is having a swelling of the upper lip, and the swelling of the upper lip was present without any local irritants in that area. So that made us the classic clinical intraoral appearance is a central erythematous area, with radiating fine and white striae, mainly resembling that of the erosive lichen planus. In case of erosive lichen planus, we generally white lesions around somewhere white lines also. So that may be a differentiating points, and there is some differentiation in the striae also of this. Unilateral the lesions is here also. The lesions are stopping at the midline and these are not crossing the midline. That made the diagnosis of a herpes zoster infection. Oral lichenoid reactions are likely to appear. See, one of the example with the male patient who was taking the treatment, some Unani treatment, and he was diagnosed. He was not having, and he was taking the Unani treatment and application there, and the lesions were developed. And the lesions were again, in such case, you should be wise enough to find and correlate that the lesions can be because of this, and you have to discontinue that treatment. See, the lesion disappears. There is no active other treatment has to be done. In this case, again, that important. See, lichenoid reaction. This is a contact lichenoid reaction rather. The metal caps which are there in patient's mouth, you may be mistaken as this of a traumatic origin, but this was not of a traumatic origin because these caps, once it has been replaced with the other material, the lesions are ultimately vanished up. So we should all these things. Reactions versus lichen planus. Lichen planus mostly bilateral, late in the age with a female predilection. Vacant striae present somewhere in the they are lichenoid reactions due to medications or long-term use of a long contact or any other substance. Lichenoid reactions are less likely to be painful than lichen shedding. What has happened, those people who can read the Marathi, they can understand itself, but those people who cannot read a Marathi, a patient had come to a doctor, how come you have broken your three teeth in front teeth? So that the patient was telling the my wife had made a roti of a hard object, then you should have, that's what I had it. It's a humor in between. And let's move further. Here last, don't worry, won't be. This is what orofacial pain. My teacher, when I was studying, graduate used to say, and his sayings are still holds true for all the academics and practitioners, that because of a pain only the patient is coming to you, and if at all while doing a procedures, if you do the pain, give the patient pain, the pain is again going to the next doctor. So pain is a bread and butter of the dentistry. So we should take up all these things. This is how is like a the patient, the your child does, you never kill that child in anger. Same way, whatever the tooth pain you are having, that should not be, the tooth should not be extracted and killed. It should be treated properly. Take care, immediate take care of the pain during the injections, and try to avoid as much of iatrogenic pain, because that is the reason why the patient won't come to you again. Okay, even if you suspect that the pain on percussion will be positive on this tooth, never percuss the tooth and see whether it is a positive. If you suspect, instead of that, ask the patient on touching the tooth, percussion is there, and do the pain on percussion testing. Use the topical ointment. These are the topical ointment, and all the topical ointment should be supplied with a fix-on powder and gel, because saliva is constantly washing it. These are the some of the lesions which are causing the pain. Now we'll be going in because of this disease, autoimmune disease, thyroid disease, neuralgia, secondary neuralgia, and medications and neurotoxicity. Sometimes even diabetes also can cause it. Okay. Now, this is a case of a trigeminal neuralgia. See, he had come to our department, and in how agony he was. Like the patient, these things, the pain. We had done a live recording of this, and this patient was telling that the pain was having on the half side of the face, and how in agony the patient was there. If you suspect such kind of a thing, then suspect trigeminal neuralgia in this case. And what has been done? What has been done is a block was administered. Block was administered. What was the immediate reaction? Where was he was getting the pain? That all things he was telling by interactions. So that is what is been immediately you should do. The patient like feels like you have helped him a lot. See the same this thing. The lady again. See how she is showing where the reactions are there and herself. The same lady was again given this thing block, and the pain was relieved. Again, this is another lady. See, once it has been asked her clearly, she is telling which all areas are painful. And here you suspect the nerve course according to the trigeminal nerve. Approach to the neuralgia, rule out odontogenic cause, do the clinical examination, IOPA, OPG, diagnostic blood, give carbamazepine and check after 3 days. Like this is called as a therapeutic diagnosis, where we treat the patient first and then we diagnose it. This entity also may come in ipsilateral dull persistent pharyngeal pain in the tonsillar fossa referred to the ear. A mass or bulge may be palpated in the tonsillar fossa, dysphagia and foreign body sensation in the throat, tinnitus, or in the cervicofacial pain. Pain may be exacerbated by the rotation of the head. That's what you should. 3 types of the. This is of academic interest: segmented, slender, and pseudo-articulated. The medical treatment combination of analgesics and anticonvulsants, antidepressants, injection of a lignocaine and a steroid, physiotherapy, and in case if doesn't work out, you go for a surgical removal. Drug reaction, harmful or unpleasant reaction resulting from an intervention related to the use of a medicinal product which predicts hazard from the further administration and warrants prevention or specific treatment or alteration of the dosage regimen or even withdrawal of the product which is been indicated for the particular treatment. This may be oral hypertensives, then beta blockers, diuretics, they may cause, and most common is hyposalivation, and with hyposalivation, the lesions, the associated lesions with hyposalivation, like there will be fissuring and dry mouth, that has to be ruled out. See some of the examples which are being shown. This is showing like that of the, this was a lichen, has, unless the drug has to be taken out, the drug is discontinued, the lesion won't heal. These are aphthous-like lesions, and like this is not actual aphthous, but these are the aphthous-like lesions that can also have a lichenoid type of the reaction. Candidiasis, which is therapy. Oral submucous fibrosis, that is again a challenge in the oral medicine. And my teacher used to say ki, like if somebody will find out some solution on this, his name will be in the Greenwich book record. So at least we treatment model, it is nearly Indian. I mean, I always say ki Indian, the whatever prevalence it is showing in the Indian subcontinent, if the same prevalence was there, would have been in the foreign country, they would have found out by this time the remedy. But we are still lacking in this, and we should work, do the measurements on the tongue present, bird-shaped uvula that has been present, and elliptical rima oris, that is opening is of the elliptical size. If you can notice, this opening is of a elliptical size. That is again a classical feature of the oral submucous fibrosis. See if you can see the this thing, bird-shaped uvula, how it is moving. The burning sensation managed with the topical anesthetics and steroids and intralesional injections that has to be given. This is what is the new, this thing we are trying without. We are designing a multi-perforated needle so that instead of pricking the mucosa 2-3 times, we can prick the mucosa at one time and deposit the solution, more solution in the same area. So this is still under research, and once the results will come out, we'll share with you again. Pemphigus, again a variety. See, it is having a bullous, bulla on the somewhere in the body also. And see, this is what is the case reported in our department. It's having a diffuse involvement. Okay, it is having some other regions also that has to be seen and observed and noticed. And if needed, a help of the skin specialist has to be taken out. So this is a diffuse involvement which was been mistaken as erythema multiplex. Take home message for the pemphigus. See, this is a classical bulla which has been seen, and the take home message for the suspect pemphigus in all chronic ulcers. Ask for the skin ulcers. Oral lesions are first to appear and last to disappear, and you should start the steroids immediately. This is a unique case during the PG life. A symptomatic patient had come for a follow-up, and once the tooth, we had taken a radiograph, there was a huge cystic like lesion which was seen and which has been mistaken for a radicular cyst. But after doing further investigations, it turned out to be a dilated odontome. Here the case which has been reported in the department, and it is looking like that of the erupted, the tooth is erupting from the lingual side, and we did a further investigations and had taken a radiographs, and this tooth with root-like structure, it turned out to be a giant tonsilate which has come, which was emerging. Radicular two varieties of it: base cyst, which are open to the root canals, and the periapical pocket cyst. Like this, one cyst can be treated with a root canal treatment, which is having this thing connection with the root canal, but such kind of a cyst needs to be a surgical excision. See, this is a case which was been reported, and it has been treated by the endodontic treatment, but always keep under observation while treating the radicular cyst, and avoid single visit root canal lesion as root canal treatment. The case which was been treated, even it was showing the classical apical puff formation on CBCT also, but can you still notice there is a lesion big surrounding it? So this was a case of a tooth cyst which was needed the surgical excision that time only, but it was been not taken, and then the lesion has grown, and the patient had turned out with a swelling, and then the lesion was excised. Okay. Odontogenic keratocyst, it has been one of the dangerous variety because it has got a high recurrence rate. The anterior posterior expansion, it is that is the classic manifestation to identify this multilocular radiolucency with anterior posterior expansion. See, this is a case one of my senior has noticed during our PG life. The small gingival swelling, it was clinically, though it was looking like of a gingival abscess, but we had taken IOPA. That time there was a cystic like a solution, and once the cyst was enucleated, that turned out to be odontogenic keratocyst. This is a classical case of a lateral periodontal cyst, which you can come across your clinic, and this has to be excised along with the tooth. See, these cases, whatever the report of these cases, these were diagnosed when the patient has come for an examination, and the patient was not aware of a malignancy in their body, and this was a metastasis which is looking like that of the pyogenic granuloma, and this was a metastasis from the body cancer, somewhere having a ovarian cancer, somewhere having a breast cancer, and this is a manifestation of those things. So these all suspicions, you should ask the related symptoms to the patients and do the necessary investigation. Again, a case of a renal carcinoma presenting as a tongue lesion. So this again a tongue lesion. Because of this tongue lesion, the lesion was diagnosed, and there was metastasis in the chest X-ray that has been done. Okay. Now this is again one of the important interesting case. The patient was having pain in the tooth and there was no carious lesion and as such no active periodontal pathology, but the patient was having a pain. So further investigation was being carried out and there was a lip paresthesia. That is the main thing which the had given a diagnosis for which had given a further way to rule out and to investigate also. And this turned out to be a metastatic breast case carcinoma, which was been initially diagnosed as a pulpal or periapical disease. Okay. This is a bony dysplasia. There was an incidental finding. Okay. When the patient has come for implant placement, right? The patient has come for implant placement and the patient then had gone the OPG. On OPG itself, some abnormality was found here and it was in further investigated on the CBCT. So you can notice the change in the bone, how it has occurred. This is dripping candle wax or flowing candle wax like appearance. And this was been diagnosed as a Leary disease, which is also called as a melorhostasis. Okay. Now, this study we have done along with Dr. Sudhir Dole and his ozone oil in the last institute where I am working, and it has turned out to be successful in treating the many painful oral lesions. And even we have presented and we have won the prize also in this case. And this ozone lesions, this ozone oil, which was been applied on the oral submucous fibrosis, benign migratory glossasis, erosive lichen planus, even some radiation mucositis and desquamative gingivitis, they were very much helpful in relieving the patient's pain. See, this is the case which we had treated with the ozone oil itself. See how the manifestation has changed. The candidial infections, it was been changed and how it has been healed. Now, recently we had come with this case and the OPG was been taken and we had done a CBCT also. Can you see what is this Rangoli competition around this, and this OPG has been cropped and been seen. Because of this, you are wanted to have a this thing apical fob. So much of the cement was been put inside, and because it has flowed through what all areas, there was only a dull pain and we were not able to diagnose what exactly the patient was having a cause. So we had advised the patient the OPG, and even the CBCT scan was been also taken for this. So how much it is been distributed in this area, can you see? So take care during your routine root canal treatment. Even some of the other radiographs also we could find evidence of the cement. See, if you can see all these cements, even in the deciduous this thing, the cement was been put inside. Here also the cement was noted down in the CBCT scan. This is an unusual case of a malignant melanoma which has been present. I mean, this patient has got a growth on the 3 months duration and blackish gray discoloration, and the patient was a female patient. She was having a denture and which was ill-fitting, and then further it was being investigated. So this is not a routine case of a melanoma. So unusual presentation of melanoma has been seen. Then this is a case where we can see, don't know, yeah, is going on. There was a dentigerous cyst associated with it. Now, little about the systemic diseases. I'll just do it fast. In diabetic patients, periodontal disease is the main concern: burning mouth syndrome, dry mouth, xyloid adenosis, fungal diseases. The well-controlled diabetic patient can be treated similarly to the non-diabetic patient: short morning appointments to reduce stress. They must not fast in order to prevent hypoglycemia. The clinician present of hypoglycemia is very similar to hyperglycemia, and if it in doubt, should be treated as a hypoglycemia always. Dental surgeons can diagnose diabetes with the help of oral manifestations. This is how anemia patient, giddiness, frequent shortness of a breath, pale oral mucosa, loss of papillae, angular cheilitis. Usually there are no modification unless it is severe. Avoid NSAIDs and aspirin. Take care of all your sterilization. In the area where we are working, the patient are always worried whether we have taken a proper care. So all the sterile instrument, washing and all those things, we generally do in front of the patient, and even the bio waste is being thrown in front of the patient to the proper disposable also. Use of a disposable syringes should be done for every injections. then these are some of the things which should you include in your routine practice to quit the tobacco and smoking habits, to make the India tobacco free. So this is what, because India is the second largest consumer of the tobacco globally, and we our duty starts that we should start taking care from our level itself. This is how I just sometimes convey the patients. Thousands of people stop smoking every day by dying. This has happened. The Indian dentists go to the foreign countries to learn the advanced technologies, but the foreign dentists come to India to observe tobacco associated lesions. Such a shame on us. Tobacco chewers and smokers are less likely to become older because they can die at young age. In take this in your practice, tobacco control and cessation and NRT products, use it, and start the patient asking the history. Make the relatives aware that this can be done, so that they will come out with many patients. This board can help you to earn like that of a full mouth rehabilitation. Like if you do this treatment quite well, there are so many people you are likely to come across. My appeal: turn from dental surgeons to oral physicians. Treat patient as a whole and not only the chief complaint of oral cavity. Pain controls on a protocol
अगर
on a
तो मुझे
priority
लगता
basis.
है
Do not neglect the
हाँ मैं बैठी हूँ
mucosal
इधर उधर चल
lesions.
जाएगा पानी
Do the proper
हाँ
imaging. Consider 3D
मेरे को बोलो
imaging in
हाउस कितने यहीं
routine
से और
practice,
बोलो मैं
whatever
भी यहीं
dice
बैठी हूँ
you are having. Then please pay attention to the tobacco habits and control. Emphasis on maintaining oral as well as a general health, and this the results will be long lasting. Thank you all. Thank you very much, and best regards to you all. Thank you.
That was a wonderful presentation, sir, and
Yeah, I tried from my best.
lots of cases, lots of documentation, and lots of lesions and conditions are explained. So let's start with questions. We have so many people here and so many
Hmm.
doctors. So there will be a lot of questions. If time is less, we can continue the questions in the group, WhatsApp group.
Yeah.
So go ahead with the questions if anyone has any questions. You can put it in chat box or you can unmute yourself and ask to sir one to one. Please go ahead. Anyone is having any question?
Is everything was clear or everything was over then? If nobody's asking the question means.
Clear, sir. It was so wonderful presentation. So definitely, even I learned so many things today. Morning only I presented my lecture. Now I learned so many things. Again,
Sir, can I ask you one question?
Yeah, sure.
My name is Dr. Nikita. I am MDS periodontist. So there is one case came to clinic. She has a lichenoid reaction. Like she had taken so many antibiotics in past 6 months because of some viral infection or maybe vaginal infection, and she had a typical sign of the like burning sensation. So what would be the? I refer to this MD specialist.
Hmm.
So as a dentist, what would be the treatment planning?
See, madam, you said the antibiotics. Generally, we do prescribe the antibiotics for maximum 7 days, right? And even though the repeated course has been done, it is less likely to cause lichenoid reactions. That's what impression I am having right now. Okay, because lichenoid reactions are likely to happen from those drugs which the patient is continuously taking.
So your voice is breaking.
Okay. So that's what my first impression, whatever information you had given, according to that, is like I don't think this is a lichenoid reaction, but what kind of a lesion exactly? Were they white or red?
She has a marginal, she had no plaque or calculus, and she has a redness on the attached gingiva and marginal gingiva. She also gave the history of hormonal imbalance, like menopause. She was 44, 45, so menopause history as well.
Okay. Okay. I mean, you're in a better position rather to diagnose the disease because it is present on the gums, right? So what I would suggest you key first of all find out if it is without any plaque and all those are there. So first off, find out whether it is having a discomitive gingivitis, which I had shown in the figure in my presentation, right? And rule out that. And then only, if needed, you can if you can easily do the exfoliative cytology of the lesion, smear if the lesion just scraps out easily, and then if not, then you can, if it is persistent, then you can go for biopsy. That's what I feel. Because the presentation, whatever you had given me in front of me, it is not clear to comment anything. But this is what is my knowledge is saying. You should proceed further.
So, shall I go for the biopsy in the next visit? If it doesn't subside, then you recommend that go for the biopsy. Is that correct?
Madam, if you can share me some photographs on my personal WhatsApp, then after seeing that, I'll be in a position to tell you for that.
Sure, sir.
Right?
Sure. I'll definitely share with you. Yeah.
Yeah, yeah.
Thank you, sir.
Yeah. Yeah, I'm back. Anybody else having a this thing? Are there any questions? I think the participants are leaving. Before that, you should ask the questions. We should ask the question. Hello.
And if anyone is leaving, will not get certificate. We are in college. It is MSDC recognized webinar, not a normal webinar. It's your choice to leave or not. Then don't message me later. I have to follow respected Dr.
Guidelines. Guidelines.
Whatever he
Okay.
said, I'm going to follow.
Should I start asking what is, I mean, once the question has been asked, how much is the time? Acha, Dr. Smita is there.
For
Hi.
doing quiz, acha, anyone is there asking? Acha. Before doing the quiz, I have something to finish off formality. Yeah, can I do it?
Yeah, sure. Proceed.
2-3 minutes. Uh, each and everyone, we have a quiz of 5 questions, and winners will get the prizes also. So before that, I would like to inform everyone that 52 faculties have registered. Of that, 20 faculties attended this webinar today. It is so much high respect to Dr. Abhay sir, and definitely faculties attending the webinar means it's huge respect. So I should mention them. Dr. Neetu Kadu from MA Rangunwala, Dr. Vishwas Kadam from CSMSS Aurangabad, Dr. Arpita Mehta, Guru Nanak Institute of Dental College, Dental Sciences, Dr. Salika Sheikh from MA Rangunwala, Dr. Salman Sayyed from MA Rangunwala, and we thank Dr. Vinod VC, HOD, OMDR Department, MA Rangunwala, who helped us to get students and doctors. Then Dr. Rishabh Kapila from Baddi Dental College, Shimla, Dr. Priyanka Lasume from MIDSR Dental College, Latur, Dr. Rajat Khajwa, GDC Doda, Dr. Manoj Ramogade, GDC Mumbai. Sorry, sir, I can't introduce yourself right now because of short time, but thank you for attending, sir. Dr. Palak Chaudhary from People's College of Dental Sciences, Dr. Supriya Sagupal, Institute of Dental College, Dr. Hatima Nigam, I can't recognize the college name, sorry. Dr. Suvarna Dongre from Sharad Pawar Dental College, HOD. Dr. Akash Ghosh from Index Dental College, Dr. Samir Gupta from Indraprastha Dental College, Dr. Sayojita Bangar from MIDSR Dental College, Latur, Dr. Samir Gupta from Indraprastha Dental College, Dr. Gigi Dr. Vijaya Bala, Dr. Kamala, Dr. Girish Patil from GDC Mumbai again. So thank you. And Dr. Rajendra Birangani sir is also here. Dr. Rajendra Birangani sir, thank you for this initiative and thank you for giving us the opportunity to organize such a wonderful webinar. And Dr. Abhay Kulkarni sir, to teach all these doctors and even us all these things. It's a very nice webinar for us. So we thank Principal of MIDSR Dental College once again and the Principal of PDU Dental College Solapur. So thank you everyone and thank you all doctors for attending also. So let's continue with the quiz.
Yeah.
Which is a very interesting part and everyone is waiting for the prizes.
Just tell me, I have to read the questions, right?
Yes, sir, you have to. Yes, sir.
And
I will note the
answers. And how much time? Any time?
Any n number of time they can, because
Okay.
the first 20 answers will be in chat box.
Okay.
Chat history later in.
Okay.
I will announce the winners, not here. So I'm not going to say anything.
So winners won't be allowed announced right now.
No need.
You'll be announcing on this thing group afterwards.
Rajendra Birangani sir also, na, before announcing. We have to inform him first.
Okay. Okay. Please, all of you keep your mind ready. And here is the question list I'll begin. So I hope you are ready with it. The first question is, how much is the normal mouth opening? I'll repeat. First question, how much is the normal mouth opening? You have to send it in the chat box. I'll proceed with the second question.
Five,
okay.
8.
Should I wait for some time, Sudhir?
20 answers, at least 20 answers. 3, 4,
okay.
8 answers are there. Yes, more. 9, 11, 12, 13, 14, 15, 16.
They can answer. I think we should move for the next question, Dr. Sudhir. That's
All
what
done.
I feel.
20 done.
Okay. See, now be ready for the second question. The second question is, disquamative gingivitis is seen in which of the following disease? One is pemphigus, second is benign mucous membrane pemphigoid, third is erosive lichen planus, and fourth is all of the above. I'll repeat the question. Disquamative gingivitis is seen in which of the diseases? One is pemphigus, second is benign mucous membrane pemphigoid, third is erosive lichen planus, and fourth is all of the above. You tell me when to start for a new question.
Just 1 or 30 seconds, sir. It will be done.
Okay.
Just 30 seconds. Okay, sir.
Yeah. Should I start with a new question?
Yes,
okay. Question 3 is enlist any 3 lesions where surgical excision is required. Enlist any 3 lesions where surgical excision is required. That is question 3. Dr. Sudhir, only 5 questions are there?
Only 5, yeah. Because we are short of time also and there are slow answers. We had decided 20 answers, but we are getting only 10, 12.
Yeah.
We have got answers. They are answering, sir.
Okay, okay. If they want time, I can wait. There is
Yeah,
no problem.
they need time because typing needs time, and this is long answer. And
Yeah.
they're answering. Once they
Okay.
stop, I'll inform you.
At least any three where surgical excision is required.
Many have answered.
Okay. Should I proceed for the fourth question then?
I request all of you, please answer fast. We're still answering, sir. Yes, sir, it's done.
Okay.
Yes, sir.
We'll go for the fourth question. All of you listen carefully. According to the literature and research papers, which of the following oral lesions can be treated with topical ozone applications? A. Lichen planus. B. OSMF grade 1 and 2. C. Non-healing ulcers. D. All of the above. I'll repeat the question. According to the literature and research papers, which of the following oral lesions can be treated with topical ozone applications? A. Lichen planus. B. OSMF grade 1 and 2. C. Non-healing ulcers. D. All of the above.
So they have answered very fast, and this question is very important for me, and I'm so happy to see the answers.
That's great. Then that's great. It's
Because
actually it's your impact probably, Dr. Sudhir.
their
Okay,
name
should I move for the next question then? Yeah.
question, yes.
The next question is take home message for pemphigus is suspect pemphigus in all chronic cases. B. Ask for the skin ulcers. C. Oral lesions are first to appear and last to disappear. D. Start steroid medicine immediately. E. All of the above. I'll repeat the question again. Take home message for pemphigus. A. Suspect the pemphigus in all chronic lesions. B. Ask for skin ulcers. C. Oral lesions are first to appear and last to disappear. And D. Start steroids medicine immediately. E. All of the above.
So this is last question, right?
Now, last question. Now, next question, last question. 6 questions are there.
There are total 100 plus chat
Answers.
till now.
Okay. Should I go for the next question then?
Yes, sir.
I don't know what has happened all the time. Okay, we on this mode. You can hear me now, Sudhir? Hello?
Yes, sir.
Hello? Yeah, should I read the next question? This is the last question now.
Yes, sir.
Should I read the last question?
Yes, sir. Yes.
Okay. So the last question is, while treating oral lesions, we prescribe antibiotics in following conditions. A. Severe anemic patients. B. All oral lesions. C. Diabetic patients with systemic history. And D. No, none of the above. While treating oral lesions, we prescribe antibiotics in the following conditions. A is severe anemic patients. B is all oral lesions. C, diabetes patients with oral lesions. And D is none of the above. This is the last question. All the best for you.
There
I
was
think you will,
there was a slide for this question, sir, in your presentation.
yeah. Nearly all these things we are having a slide, probably.
Yes.
Dr. Sudhir, you will be giving those, I mean, the winner's name will be announced on the WhatsApp group afterwards, right?
Talk
Okay.
to Dr. Rajendra Virangane, sir, and I'll take permission from him, and then I will announce in the group tomorrow,
Okay.
or give me time. And most of them are right.
Okay. Okay. No, you,
All
yeah,
are,
1 or 2 days you can take, because they all are in the group. There is no question.
yeah,
So are we on, we are ending it. So I do thank all the faculties which have attended my seminar and supported this activity. Some of them I am knowing. Dr. Vishwas Kadam sir, probably I am knowing. Dr. Uma, probably I am knowing. Yeah. Rest all, there are some new members. Probably I got introduced to them right now. And what is my appeal to them, that I'm this thing. I mean, you all can put your this thing names on my personal WhatsApp number, and I can take you into the National IOMR group. I'm a basic admin of National IOMR group. So I'm thankful to you all. Some of my students are also there. My friends are also there. I think Dr. Smita Chopade from Kolhapur, she had joined, and Dr. Supriya, and Sudhir. Dr. Sudhir, I think you had forgotten one name. Dr. Vijayalakshmi Male, she was head of the department of MIDSR Dental College. She was also there, and
okay.
Dr. Rohini Divekar. She is a faculty at MIDSR Dental College. She is also there, and thankful to all, and special thanks to Birane sir
Have,
for supporting us.
that's why they are coming by name iPhone or
Yeah, yeah. Okay,
OnePlus.
okay, okay,
Sorry.
okay, okay. So we had taken their name. Okay.
Yes, sir.
Chalo, thanks to Dr. Sudhir again, once again taking the initiative
Thank you,
and
sir.
making this webinar. I hope I'll get a chance to work with you in the future also, and having such kind of activities in future. Okay.
Actually, I met all these the OMDR people. That's my pleasure to learn, and in
Yeah.
future also
Then
contact them. So finally, thanks to Dr. Rajendra Birangane sir.
uh,
He has a lot of effort in this project, and the principal of
okay.
MIDSR College and PDU Dental
Dr.
College,
Suresh Kangne sir.
Dr. Suresh Kamble sir.
Yeah.
Okay, and if I have forgotten any name, all the my friends and dentist colleagues, thanks to you for joining here. So let's meet in the next webinar, which is tomorrow only, ADC webinar by Dr. Rinku Lunia. It is on rubber dam, all about clamps. So anyone is interested, you can join. You know where to join, the links, the numbers, everything is there. And for this topic, oral lesions, the common and suspicious entities in oral medicine, definitely you can put your all questions in the group. Sir is available there in the group, and that group will be there for discussion. And please put the photographs of the cases so that sir can answer in better way. So can we conclude,
Yeah.
sir? Should I conclude
Yes, sir.
the?
No problem. Thank you very much.
Thank you,
Yes.
sir. Thank you.
Yes.
Thank you
Thank you.
so much for the webinar. I'm ending the.